Good afternoon. On behalf of my fellow investigators, I'm pleased to present updated Phase 1b pan-tumor data from over 400 patients with advanced solid tumors treated with botensilimab and balstilimab. You see here my disclosures related to my external activities. I'd like to first recognize the decades of work that has advanced the IO revolution and reshaped cancer care. Today, about 60% of patients have access to approved IO therapies sometime during their cancer journey. Yet responses remain concentrated in immunogenic, or the so-called hot tumors, and only about 11% of patients have an objective and often a durable response to approved IO therapies. Therefore, the need for novel treatments to extend the benefits of IO to more patients is urgent. Botensilimab is a novel Fc-enhanced anti-CTLA-4 antibody designed to expand the reach of immunotherapy to historically cold or IO refractory tumors. Balstilimab is a clinically validated PD-1 antibody used in combination with botensilimab. The following results on over 400 patients with cold or IO refractory tumors, a population historically resistant to IO, and align with findings previously reported from our previous 125 patient disclosures. This first-in-human study was expanded based on broad efficacy signals to enroll cold and IO refractory tumor cohorts. Patients received botensilimab at 1 or 2 milligram per kilogram every 6 weeks and balstilimab every 2 weeks. And as of the cutoff in March 2025, 411 patients received the combination. Participants had cancers historically unresponsive to IO, such as microsatellite stable colorectal cancer, soft tissue sarcoma, and treatment refractory ovarian cancer. Alternatively, they had warm or hot tumors like non-small cell lung cancer and melanoma that had progressed on or after prior IO therapy. This was a heavily pretreated population with a high burden of refractory and multi-organ metastatic disease. 61% of patients had 3 or more prior lines, and 1/3 of the patients had prior IO therapy. 69% had multiple metastatic sites, and 31% had active liver metastases. The confirmed overall RECIST-based objective response rate was 17%, with no difference between the botensilimab doses. Remarkably, median duration of response was nearly 15 months, with 66% disease control rate. These waterfall and spider plots illustrate the response depth and durability, including prolonged stable disease in a population not expected to respond to IO therapy. Personally, I recall a patient of mine with a large 32 centimeter dedifferentiated liposarcoma in her abdomen, which had limited all of her function and activity. And after 2 years of combined BAL therapy, that tumor has now regressed to about 19 centimeters. She's fully functional and exploring the option for potentially curative surgery that did not exist previously. Consistent with historical IO experience in hot tumors, durable responses translated into a remarkable median overall survival of 17.2 months and a survival plateau, a hallmark of anti-tumor immunity. With 13 months of median follow-up, nearly 40% of treatment refractory patients were alive at 2 years. Overall, treatment was well tolerated with no treatment-related deaths. Efficacy was similar across doses, but adverse events were less frequent and lower grade when botensilimab at 1 milligram per kilogram. This, along with randomized phase 2 data, supported the selection of the phase 3 BATMAN trial in metastatic microsatellite stable colorectal cancer. No new anti-PD-1 or CTLA-4 class safety signals emerged, and key immune-mediated events such as hypophysitis, pneumonitis, and hepatitis were absent or occurred at comparably low rates. High-grade visceral toxicity was rare outside of the GI tract. Diarrhea and colitis was the most common immune-mediated adverse event and was reversible with timely short-course steroids and early anti-TNF-alpha therapy, allowing patients to use less steroids and continue BAL on schedule. This large population enabled exploratory subgroup analyses. A longer median overall survival of 23.8 months was observed in patients experiencing immune-related adverse events during the first 12 weeks of therapy, compared to 13.8 months without. This is consistent with other IO datasets in solid tumors. High-grade immune-related adverse event-related discontinuation or anti-TNF-alpha use did not negatively affect the overall survival of patients treated. Further exploratory analysis of liver metastasis status showed notable responses in both patients with and without liver metastases, although responses were more common in patients without. Similarly, responses were seen in refractory patients who had progressed after prior IO treatment, a historically difficult to treat subgroup, with greater efficacy observed in the IO naive patients. Overall, these mature findings from a large trial of botensilimab and balstilimab in refractory solid tumors reinforce and expand on our early data. Across a broad range of cold, IO refractory, and heavily pretreated tumors, patients demonstrated durable responses, high disease control rates, and remarkable survival extending beyond 2 years. Comparable efficacy was seen across both botensilimab doses, with a more favorable safety profile at 1 milligram per kilogram, the dose selected for phase 3 analysis and endorsed by the FDA and EMA. Responses were observed irrespective of prior IO or liver metastases status, and longer survival was observed in patients experiencing immune-related adverse events. Looking ahead, development includes the phase 3 BATMAN trial in late-line microsatellite stable colorectal cancer, alongside earlier stage neoadjuvant trials in colon, rectal, and other solid tumors. I'd like to say thank you to our investigators, study staff, and most of all to the patients and families who participated in this trial. Thank you very much.